Hello. Welcome back to the ERMP and Beyond YouTube channel. Today we will discuss on Case 13 from the 2021 ERMP recall questions. A 67-year-old male patient is admitted to ward after he presented with a complaint of shortness of breath, body swelling, paroxysmal nocturnal dyspnea and orthopnea of 2 pillows. Blood pressure is 120 by 80 mm mercury, pulse rate is 90 beats per minute and regular. Echocardiography showed left ventricular ejection fraction of 30%. What is the drug that doesn't have mortality benefit for this patient? A. Metoprolol. B. Digoxin. C. Enalapril. D. Spironolactone. Cardiovascular pharmacotherapy for heart failure with reduced ejection fraction has evolved significantly, with a focus on drugs that offer a mortality benefit. The cornerstone of treatment for heart failure with reduced ejection fraction includes a combination of medications that have been shown to improve survival rates. In the context of heart failure with reduced ejection fraction, where the left ventricular ejection fraction is 30%, as in the case of the patient described, the mainstay of treatment includes medications that have been shown to improve mortality and morbidity. These typically include angiotensin-converting enzyme inhibitors, angiotensin II receptor blockers, beta blockers, mineralocorticoid receptor antagonists, the combination drugs sacubitril/valsartan and most recently, sodium glucose cotransporter 2 inhibitors. Beta blockers are a class of medications that reduce the workload on the heart and help it to beat more regularly. They achieve this by blocking the action of hormones in the body, like adrenaline. This action helps to lower blood pressure, reduce chest pain, and prevent heart attacks. In the context of mortality benefits, beta blockers have been shown to significantly improve survival rates among patients with various cardiac conditions. For instance, in the aftermath of an acute myocardial infarction, beta blockers can reduce sympathetic activation, which is beneficial because this activation can lead to infarct expansion, increased propensity for sudden cardiac death, and over the long term, ventricular remodeling in heart failure. Studies have demonstrated that immediate use of beta blockers post-MI can reduce infarct size and increase the threshold for ventricular arrhythmias, thereby providing an immediate mortality benefit and preventing long-term maladaptive ventricular remodeling in heart failure. Furthermore, beta blockers are now considered standard therapy for patients with heart failure, particularly those who are hemodynamically stable and do not have dyspnea at rest. Large randomized controlled trials have shown that beta blockers, when added to standard therapy including angiotensin-converting enzyme inhibitors and diuretics, can lead to a significant improvement in mortality rates. This is particularly true for patients with New York Heart Association Class II or Class III heart failure. Additionally, beta blockers have been associated with a lower risk of sudden cardiac death, cardiovascular death, and all-cause mortality, with reductions of 31%, 29%, and 33% respectively. These results underscore the importance of beta blockers in the prevention of sudden cardiac death and their role in comprehensive cardiac care. Specifically, the beta blockers bisoprolol, carvedilol, and sustained-release metoprolol succinate have been shown to reduce the risk of mortality and hospitalizations. They are a cornerstone in the management of MI, heart failure, and in the prevention of sudden cardiac death, contributing to improved survival rates and quality of life for patients with cardiovascular diseases. As with any medication, the use of beta blockers should be individualized based on the patient's specific condition. The evidence supports their role in reducing mortality and improving outcomes, making them a vital component of cardiac therapy. Aldosterone antagonists, such as spironolactone and eplerenone, are medications that block the effects of the hormone aldosterone. They are primarily used in the treatment of heart failure, hypertension, and certain conditions of excessive aldosterone production. The mortality benefits of aldosterone antagonists have been well documented in various clinical studies. In patients with heart failure, particularly those with reduced ejection fraction, these drugs have been shown to reduce mortality in hospital readmission rates. This is achieved through their ability to prevent myocardial fibrosis, reduce ventricular remodeling, and decrease the risk of sudden cardiac death by mitigating potassium loss and improving myocardial uptake of norepinephrine. In the context of acute myocardial infarction, especially in patients without heart failure, aldosterone antagonists have been associated with a significant reduction in mortality. This effect is thought to be due to the prevention of adverse cardiac remodeling and the attenuation of myocardial fibrosis. Moreover, the phenomenon of aldosterone escape, where aldosterone levels rise despite the use of ACE inhibitors or angiotensin receptor blockers, provides a rationale for the use of aldosterone antagonists in a broader range of cardiovascular diseases. The therapeutic strategy of interrupting the renin-angiotensin-aldosterone system with these antagonists is a cornerstone in the management of chronic heart and kidney disease. By blocking the detrimental effects of aldosterone on the heart and kidneys, aldosterone antagonists contribute to improved clinical outcomes. This includes a reduction in the progression of heart failure and a decrease in the incidence of sudden cardiac death, which is a significant cause of mortality in these patient populations. It's important to note that while the benefits are significant, the use of aldosterone antagonists must be carefully managed due to potential side effects such as hyperkalemia and renal impairment. Angiotensin-converting enzyme inhibitors are a class of medications that have been shown to have significant mortality benefits in various cardiovascular conditions. These benefits are particularly pronounced in patients with heart failure, left ventricular systolic dysfunction, and following acute myocardial infarction. ACE inhibitors work by inhibiting the conversion of angiotensin 1 to angiotensin 2, a potent vasoconstrictor, thereby reducing blood pressure and decreasing the workload on the heart. In the context of acute MI, most randomized trials have demonstrated that ACE inhibitor therapy, when started within the first few days post-MI, improves left ventricular ejection fraction, and is associated with an important improvement in patient survival. Long-term studies, such as the acute infarction ramipril efficacy study, have supported the sustained survival benefit of ACE inhibitors. For instance, ramipril, an ACE inhibitor, was shown to extend life expectancy by an average of 14.5 months in patients with heart failure following acute MI. The benefit was even more pronounced in patients with additional risk factors such as diabetes, previous MI, hypertension, and angina. In addition to their role post-MI, ACE inhibitors are a cornerstone in the management of chronic heart failure with reduced ejection fraction. They have been consistently shown to decrease cardiovascular mortality, MI, and hospitalizations for heart failure in patients with symptomatic or asymptomatic left ventricular systolic dysfunction. Moreover, ACE inhibitors have benefits beyond cardiovascular mortality reduction, such as delaying the onset of type 2 diabetes and lowering the risk of stroke and kidney disease, which further contributes to their overall mortality benefit. Clinical practice guidelines recommend the use of ACE inhibitors at the maximum tolerated dose, based on the evidence that higher doses may provide greater neurohormonal blockade, which is beneficial in chronic heart failure management. However, it is essential to balance the dose with potential side effects and individual patient tolerance. Sacubitril/valsartan, marketed under the brand name Entresto, is a combination drug containing the neprilysin inhibitor drug sacubitril and the angiotensin II receptor blocker drug valsartan. By combining neprilysin inhibition with ARB activity, RNI achieves a dual effect, enhancing beneficial peptides while counteracting the harmful effects of angiotensin II. It has shown significant benefits in the treatment of heart failure with reduced ejection fraction. Clinical trials have demonstrated that this medication can lead to a reduction in the risk of death from cardiovascular causes and can also decrease the number of hospitalizations for heart failure when compared to enalapril, a drug previously standard in the treatment of heart failure. Specifically, patients treated with sacubitril/valsartan experienced a 16% reduction in death from any cause, which translates into an estimated 1.5 to 2-year increase in life expectancy based on actuarial analyses. Moreover, sacubitril/valsartan provides a mortality benefit by decreasing heart failure-related hospitalizations over and above an ACE inhibitor. It is recommended for use in place of an ACE inhibitor in patients who are already receiving optimal doses of guideline-directed medical therapy, which includes ACE inhibitors, beta blockers, and aldosterone antagonists. This recommendation is particularly significant as it suggests that sacubitril/valsartan can be more effective than the established treatments in certain patient populations. It's important to note that while sacubitril/valsartan has been a breakthrough in the management of heart failure with reduced ejection fraction, its role in heart failure with preserved ejection fraction is less clear. Sodium glucose cotransporter 2 inhibitors, a class of medications ending in -flozin, such as canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin, have been shown to significantly reduce mortality and improve cardiovascular outcomes in patients, regardless of the presence of type 2 diabetes, heart failure, or chronic kidney disease. Clinical studies have demonstrated that treatment with SGLT2 inhibitors can reduce the risk of mortality due to all causes by 16%. Similarly, cardiovascular mortality is reduced by 16%. Hospitalization for heart failure is also notably decreased by 31%. Furthermore, sodium glucose cotransporter 2 inhibitors contribute to renal protection, reducing the composite of end-stage kidney disease, a doubling of the serum creatinine level, and kidney-related mortality reduction by 38%. These benefits are consistent across patients with or without diabetes and with or without heart failure, highlighting the broad applicability of these medications in different patient populations. The reduction in all-cause mortality and improvement in cardiovascular and renal outcomes underscore the potential of SGLT2 inhibitors to be a transformative treatment option in modern medicine. It's important to note that these medications should be started at low doses and gradually titrated to target doses based on patient tolerance and vital signs. For comprehensive management, these drugs are often used in combination to provide a synergistic effect, improving patient outcomes. On the other hand, digoxin does not have a mortality benefit for patients with heart failure with reduced ejection fraction. While it can improve symptoms and reduce hospitalizations by increasing the contractility of the heart, it does not have a direct impact on long-term survival. Therefore, among the options provided, digoxin, B, is the drug that does not offer a mortality benefit for this patient. Thank you for watching. Please like, comment and subscribe for more similar discussions.